Some of this clearly is a formality, and since we are in health fits into this difficult period we are going through. Before we go on to this panel and ask them for their views, we're going to ask Savannah very briefly to walk through the tech, just so that you know how to get engaged. And I will give a very brief overview on what we've done as National Voices with and on behalf of our members during the first wave of the pandemic. Savannah, very briefly, how can people get involved?
Hi. So firstly, I'll just say that the Zoom call is recording, just so everyone knows. And yeah, if you have any issues with tech, you can private message me on the chat or send me an email. But yeah, if you private message me on the chat, so there's that chat function right at the bottom there, and you can choose who you send messages to, and that's how you can get involved throughout, put questions down there. You'll all be muted, and if you do want to unmute yourself, then that button is bottom left, and you can also choose whether your video is on right next door to that. And you can change your view and whether it's full screen, top right there. And just there, bottom right, that is how you change who your messages in the chat are to. So if you're asking for a question, then you'd want to have it on everyone. But if you want to send me a message about tech, then you can change that.
Thank you, Savannah. And Savannah has just joined us very recently on a temporary basis to support our influencing work, and has been, making a massive contribution already. The team we've got on the call today is Charles, who's our new comms manager. I don't know whether any of you have met him yet, but you might have seen him on member news and so on. He's going to staff Twitter for us and let the world know that we're here today. And we've got Jess, who's taking minutes and also looking at the chat and making sure that we pick up your questions and concerns and suggestions. And Rebecca, who's our head of policy, who is also looking at the chat. And I think Rachel is also on the call. She's leading our big flagship project in collaboration with the Health Foundation on understanding how patients, service users and their experience can be more central to improving health and care services. So that's our team. We're a very small organization. A couple of people are off sick. I've just said that to Richard, one of our panelists. It seems to, the effect of the pandemic seems to hit us harder in the second wave than in the first as the National Voices team. Before we hand over to our very esteemed panel and engage in a discussion with them about the future and the present, I just want to give a very quick overview on what we did. So we talked about last year in the hour that just passed, and it was a difficult year because we had to transition to a really new way of working. We had to recruit a new team. It's not been the easiest year, and slightly naively, I thought as that year was drawing to a close, things were going to get easier this year, and I couldn't have been any more wrong. Obviously the pandemic kicked off around about March this year. Maybe it did earlier, but we weren't aware of that, and we had to very quickly make decisions on what our contribution was going to be on behalf of our members and all the people we support. And became really apparent very quickly that people who normally use health and care services quite a lot, and those are the people who our members on the whole support, people with substantial health and care needs, were very severely affected by the decisions that were being made in order to get England and the UK through the pandemic. We say this not in a spirit of blame. The health system needed to be pivoted towards providing huge amount of COVID care, but we felt it was really important to document how people who use health and care services for all the things that aren't COVID were living with these decisions and the impacts this has had on their lives. And we're pleased to report that this seems to have worked really well. We've gained quite a large number of new members. Some of them are joining us here today, which is just wonderful. Because all our engagement moved online, we managed to reach people and organizations outside of London who have very small or no staff teams. And our new membership really reflects that. We've got members looking after inequalities group. We've got members from outside of London, from the north, which is just brilliant because we've always found it really hard to work in this inclusive way when we were much more relying on face-to-face meetings. So for us, the move to online engagement has really made us more accessible, I think. So we had conversations, huge amount of engagement, 600 individuals from hundreds of organizations tuned in and got engaged. And when you look at the chat, and we've always tried to make this chat available to people participating in the webinars, what really strikes us looking back at this work is how open the conversations have been. We had people with health and care needs, we had very small volunteer-led charities, we had large brand name charities, we had service leads from all the different statutory agencies, and we had academics and think tank colleagues, all of us joining together to try to make sense of what was going on. Really deep, useful conversations. Importantly, we created our COVID voices and invited people who normally use health and care services quite a lot to tell us about their experiences during the pandemic. And we've worked with a researcher who crunched all this data and helped us understand what it told us, and we've taken it far and wide and are taking it even further. And we also created, quite early on in the pandemic, a set of 5 principles which have been shared far and wide, which almost 100 of you signed up to, which kind of in a way set out how we need to maneuver our way through all the very difficult decisions that are lying ahead. I should have started screen sharing and I didn't. Savannah, can you just keep going with sharing the slides? I'm so sorry, I forgot. So we had some influencing successes, and when Savannah's ready, she will, oh yeah, there we go. We spoke at the APPG for Health, we spoke at the Health and Care Select Committee. We have been invited to join the NHS Inequalities Task Force, and I'm now also on the implementation oversight group of that task force. We kind of rolled our sleeves up a bit around those decisions. I don't know whether any of you remember, Public Health England engaged with hundreds of community organisations about the discrepancies around outcomes from COVID, and then decided not to publish what they had heard from all these community groups. And we thought that was not the way to engage with the VCSE and with communities. So we got quite involved there and managed to turn around that decision. And as I mentioned earlier, we have written to ministers around particularly the shielding programme and support for people who are vulnerable to the virus. We are yet to have a response. And I think that resonates with the experience of a lot of advocates, that it's been really very difficult to engage with central government. I will now very briefly walk you through some of the outputs we've generated. The first one, and we're so pleased how quickly we got out of the starting blocks with this, which helped us have really very massive impact with this piece of work, is the Doctor Will Zoom You Now, where we contributed to work that we did together with Traverse and Healthwatch England around people's early experiences of having their care moved to remote and online models. And this work focused on people who were able to access online care. We then complemented that by doing often landline interviews with 20-something people who are more at risk of exclusion. Some of them had also used online models, and some of them reported that those were very good experiences, but some of them said they could not make head or tail of the offer that was made from their GP, let's say. And we spoke to some carers who said, you know, their elderly relatives could not engage with the offer of a diabetes check-in that was made online, let's say. We came up with some really practically focused recommendations, and I really encourage you to look at that report. It's just a really good what to do and what not to do around moving care online. We then, the next thing we rolled out we got out of the door this autumn was a piece of work. Again, we started before the pandemic around the VCSE's experiences of the rollout of social prescribing. You'll be aware that social prescribing is sort of an attempt to more strategically and effectively interface the contribution charities and community groups can make to health and well-being with largely primary care. And we talked to over 300 charities. We were commissioned by NHS England to do this work, and we were holding a lot of contradictory views, some very strongly held views around this. But I'm really pleased to report that we managed to write this all up in a way that NHS England could actually hear it, because lo and behold, if you scream at people, they're less likely to hear you. So NHS England have given us great feedback on this work, but very pleasingly also the charities we engaged with and the sector whose views we tried to represent said we did a fair job. And we're now working on a follow-up project which tries to, in a way, crunch through all the recommendations we're making in the report and tries to disentangle what's for NHS England to do and what's for wider government agencies to sort out. And the next piece of work I want to just briefly mention to you is patient noun adjective, which is about people's experiences of having their care disrupted or delayed or cancelled. And again, we spoke to a few more than 20 people in deep detail about what this did to them, also to carers, and what they would have found helpful in order to get through these waits more with less distress. And this is obviously, we just launched this last week, was it? Or the week before, it's all a bit of a blur. It's very, very timely, obviously. We've got over 4 million people now waiting for elective care. And as you are all aware, the cancellations are starting again in the areas where the NHS is busy looking after COVID patients. Of the 22 people we spoke to, no one had their referral acknowledged, for example. So again, we came up with some very practical solutions for what services can do to make a wait less distressing and harmful. And again, I'm really pleased to report that we are in a working group now with some colleagues from NHS England and some royal colleges to explore and to tie down what a minimum support and information offer needs to look like for people who have their care disrupted or delayed. It's a bit sad that this needs saying, but we need to remind the NHS that they need to communicate with people whose care has been affected by this pandemic. And hopefully we will get to a high standard of information that will be provided. Finally then, to wrap it all up, we worked with people directly affected by the pandemic and with our members, and we combined all this insight into 2 flagship reports. The first one is What We Know Now, which basically is a overview analysis of the surveys our members themselves conducted with their communities and cohorts. It is based on 66,000 responses from people. Again, we worked with a researcher who gave us her time for free. We're very grateful for all the help we had from people who were furloughed and volunteers during this really difficult period. It's not surprising what this report tells you, but it's beyond a doubt now, I think, that harm has been caused to people who live with long-term conditions and disabilities in particular. And then the second one is a much more qualitative piece of work where we took the first 50 stories people told us on our COVID Voices platform, worked with a researcher who did some clever things with software I wouldn't even know which way around to hold, and arrived at a sort of topic list. We then convened a number of focus groups with people who had given us their experiences and asked them to crunch these topics, but also to tell us what they wanted to happen now, what they needed now on the basis of their experiences. And we produced this beautiful set of I statements, which Savannah is going to show you now. You can download all these images and use them in your own work, the ones that resonate most with the work you do. And I do believe you are all over all of these agenda items, you know, because you are all lobbying for better care planning, for better shared decisions, for better care coordination, for better emotional support and practical support for people. We're having really interesting and promising conversations with system leaders about these statements, and we worked really hard to turn them into a set of practical recommendations as to what people who design services and people who deliver services can actually do to realize these ambitions, because we understand it's not good enough in a way to sort of pose these challenges. We need to also, in a way, make it practical, and that's very much what National Voices has tried to do. I'm pleased to report that we got a bit of pickup in the media with all of this work we've been doing during the first wave of the pandemic. Given we don't really have a media team, this is pretty amazing, and largely to do with the fact that I think we've generated some really interesting and important content. So this is a bit of a canter through the work we've been doing very much supported by all of you, to put on the record what's going on for people. And one thing that really struck me, looking back at the last 6 or 8 months, is how much of an authority, in a way, this gives us as national voices. If we stick close to what people tell us is actually going on for them, we can't go much wrong, I think, in terms of our influencing. And it's been really heartening to see that where we intelligently translate these experiences into things the health service can actually do to make things better, that we get to hearing. Right, I'll stop there, and I'll introduce our panel, esteemed panel of speakers, who will give a very short opening statement, really, about where they think we're at right now with health and care, and also where they think we as the BCSE in health and care fit into this picture. What do they think we should do? And I'm pleased to introduce the following 3 panelists. We've got Ben Jupp, who is the relatively new Director of Strategy at NHS England. What a time to join the NHS. Welcome, Ben. We've got Richard Sloggett, who used to work as the Special Advisor to Matt Hancock and is now leading all the work on health and care for the think tank Policy Exchange. And we've got Sarah Hughes, who is the CEO of one of our member charities, the Centre for Mental Health, who will talk to us about mental health and where we're at with the pandemic and the third sector in all of this. I'll start with Ben, if you don't mind. Ben, where we're at and what do you think we as the charity sector should do?
Thanks, Charlotte, and it's great to be with you. I have to say, due to our NHS non-Zoom technology, where I'm not even allowed to download Zoom, I'm on my iPhone, so I hope you can hear me okay. Is that okay? And it does mean that I know there's people I've, old friends on this webinar as well, but I can only see 4 people at once. So lovely to see some of your names. And as Charlotte says, I'm fairly new into NHS England and improvement, just starting the strategy job since August, although in late June and July worked on health inequalities on a part-time basis. My background is a mixture of having worked on community and preventative care projects for the last 8 or 9 years, but before that having some strategy roles in government and being about 15 years ago director of the Office of the Third Sector, as it was called now Office of Civil Society. So, I mean, firstly, I just wanted to reiterate the amazing work which National Voices is doing during this time, and I know that's not what we're talking about, but I do want to celebrate that as well, because I think in the fields that I work on, whether it's the way in which your kind of key principles around COVID was front and centre in the letter which Simon Stevens sent out to the whole of the NHS at the end of July, or whether some of the areas that I've been working on, particularly on health inequalities, shielding, is one of the areas I'm responsible for as well. And I know that maybe DHS hasn't come back to you on your formal response, but I can absolutely tell you that around the many Teams chats of all those across government involved in shielding, reports like yours, which are really clear, really concise, hard-hitting but constructive, are whizzed around and have an enormous impact. And I'd also just like to say, my experience of working with you, Charlotte, on the Health Inequalities Task Force kind of represents that as well, because it's an example of being both fearless and practical. And I think when we started thinking as a group of people from within the NHS, leaders and beyond, in July about what the kind of recovery from COVID, but also always aware that it could be a second wave, looked like, we were quite focused on, okay, well, let's get back to how people are using elective care, critical services, cancer care, all those things which are incredibly important and which you're mapping. But you were like, actually, just a sec, you've got to start with a position that there are millions of people who have had an incredibly difficult time, that we've got a duty to protect them, support them, engage them. And that was very powerful because it really brought that perspective, and did lead to that being the first recommendation about protection and engagement in that work that you were involved in. So I think we want to have lots of time for discussion. I mean, I would just say a couple of things. Firstly, is not only National Voices, but a number of organisations on this call will feed into things such as the Health and Wellbeing Alliance. And actually some of this work was just starting off about partnerships and things like that when I was in the Office of the Third Sector about 15 years ago, strategic partner programs. I'm sure there's been ups and downs. It replaced a system where people came in, and if they had a good chat with the minister might say, could we find a little bit of money for that organisation because they're great. And I inherited like a list of about 60 organisations that were brilliant, but were sort of totally varied. And whilst I know it's not perfect, actually, if we just think about how important that's been during COVID, the rapid kind of weekly, 2-weekly feedback on what's going on, rapid learning on those sorts of things which you identified, that won't be the case, but we've made everything, been successful on everything. But I tell you, it would be better than if we didn't have that. And going forward, I know the work on long COVID, one first, a number of a kind of general practice, bureaucracy work coming up, flu, and then COVID vaccination. These are all really critical. So when I was reflecting on this, I thought, well, what is really important? And we all know that VCS covers so many different things. It's hard to pin down what are the one or two things which will be really important going forward. And the role of organisations as being really high quality, community engaged delivery organisations is critical, because we're going to need a lot of innovation in a lot of different areas. We're talking about social prescribing, for example, and the importance of personalised care for vulnerable groups going forward, particularly who've had a very difficult time over the last few months and will continue to have a very challenging time, is really, really important. But I would just highlight two things really, which I think are important, particularly important going forward, which is a very, reflects the membership here. The first is voice, and the second is mutuality, because those are things which the organisations on this call can facilitate and enable in a way which it's very, very hard for other organisations to do in the statutory sector or the private commercial sector. And those have always been important, but why are they going to be even more important? So I think we've got to recognise that as putting beyond just kind of the NHS and health and care, we've got a huge number of challenges which in many instances compound some of the challenges around economic and social thriving, which we have all been concerned about and struggling with. And both of those require models of mutuality and support between people, as well as embedding that within the way that public services such as the health service engage with people. And secondly, it requires voice for everybody, because everybody is a user of the NHS, but particularly for those who have less power than they should and suffer unequal consequences. And given the number of changes given the number of challenges and the number of changes which are going to come about, we talked about the elected backlog, but also the positive things which we can learn about how services can adapt and which we want to accelerate. Those will be incredibly important. And I think I'll end just by saying that the challenge, it always strikes me, is how do we keep that voice and that mutuality person-centered, human-centered, locally centered, whilst also being able to bring that together with the rigor which allows this to have a meaningful and informed process on things such as resource allocations, which and guidance to the NHS, which does need to be based on quite detailed insight and understanding and data and the like. And I think that's where actually you working together and investing with support from others in things such as taking voices and understanding that and turning that into deeper and wider insight is really helpful. And equally on the mutuality side, how can the networks which are together on the ground be an even stronger part of the ecosystem around health and social care at local level going forward. Those are just some introductory remarks about voice and mutuality, but also about thanks.
Waiting for that error to creep in. Thank you so much, Ben, for your kind words, but also for that really interesting challenge. And I think that's something that, as the VCSE, we're all very aware of. How do you stay at the human scale, and how do you bring that authenticity of voice to the challenge while sitting at the top table and understanding the kind of mechanics and the requirements of larger data sets and more reliable evidence? I think that's a real important challenge for us to think about now and in the new year. Right, I'm now going to hand over to Richard for a similar set of brief reflections before handing over to Sarah Hughes. Thank you.
Thank you, Charlotte. And I completely concur with Ben's comments about the impact that National Voices is making. I think particularly on the creation of evidence, which is so important. We did a piece of work, a policy exchange, looking at the technological changes that have come in as a result of the pandemic. And the gap that we saw was this whole piece around what impact is this having. There was a sort of presumptive hypothesis that this was a great thing, but we weren't seeing any of that direct patient or public feedback. And I think one of the sort of gaps you're filling is exactly that. So for certain groups, it will be very helpful. For others, it will be less helpful, and we need to capture that evidence. So I completely concur with Ben's comments on that. It's really helpful work. So I think it's great. I was going to give you some reflections on the sort of political policy landscape, which is obviously very challenging in and of itself. So I thought I'd take you through a little bit about government healthcare policy and where things have got to, and how the voluntary sector could fit into that direction of travel. And you made in your opening remarks comments about how difficult it's been to get in front of ministers and to have conversations and engagements. And hopefully through the Q&A and conversation, we can talk about some suggestions and ideas about how to sort of unlock that, because it's clearly a very difficult time for everyone involved. I mean, first thing I would start by saying is that health was already probably the most important issue this government had and was facing, even beyond Brexit. If you looked at the election, which is less than a year ago, I mean, it's amazing how quickly time flies. But last December, when you were looking at the polling going into the election, the NHS was back up at the #1 issue. If you look at the Mori data, it was even more important to voters than Brexit. And that led to the government going into the election with these very high profile and quite political health commitments. When I was in government, we worked a lot, very closely with NHS England on the long-term plan, on the prevention green paper, and on a whole range of different policy issues. So we've created NHSX on the technology side. I think since August and July last year, what we've seen actually is much more of a sort of stronger political lens put on some of these headline commitments. So whether that's the 50,000 more nurses, 50 million GP appointments, 40 new hospitals, the commitments that are regularly repeated by the government that went into the election. And then on the back of the election, there was a very strong focus before COVID on actually how you take those headline commitments and translate them over the next 5 years into deliverables. And one of the interesting things about the first lockdown and the first stage of the pandemic is actually how committed the government was still over the course of this parliament to delivering on those promises. It sees them as an issue of public trust and engagement. So those things that were in the manifesto, what hasn't happened is, as a result of COVID, they are being watered down. They're, if anything, being recommitted to, even though obviously we're in a period of huge uncertainty. And if you looked at the election itself, I mean, the Secretary of State, I think, visited 125 different constituencies across the country to go and talk about the health service and the transformation of the health service and the rest of it. So health is so important to this government. And what that then means is when you then put a pandemic in from March onwards, it just ratchets up the volume to such a significant extent that there is now huge amounts of political risk, not only in the COVID response, but probably of even greater importance over the longer term is going to be the non-COVID healthcare response. And Ben's already talked a little bit about the backlog of care that's building up. But there is this piece about the formal backlog, people who are on lists or have need that's identified. But I think there is something building up which is much bigger, which is the population health needs, which is more informal and is less easy to capture, particularly when service access is more restrictive. And that is more of your population health need. So if you think about the unemployment challenges that we're going to face and the knock-on impacts on people's mental health and housing and these range of issues, what we're seeing is there's a lot of focus on this formal line of healthcare needs. And, you know, we're talking about waiting lists of 4 million, 8 million, 10 million. But beyond that is a huge sort of mecca of informal healthcare need, which is building up every day that we go through this process. And for the voluntary sector, which plays a really important role in filling the gap between formal and informal services, that sort of need is going to only be greater as we move forward. I think the pandemic's done a few different things to healthcare services, which I think are worth sort of unpacking a little bit, and then I'll come on and talk a little bit about sort of opportunities for the voluntary sector. There's clearly a move at the moment, which I think is an interesting one, these sort of regional healthcare structures within the NHS. And Charlotte, you talked in your response to Ben about this challenge around person and system. I think there's also now, because of the structures of the system are so complicated and so diverse and so mixed, the engagement between the different bits is very difficult for people to navigate. And it's always been a challenge in a complex system about how do you, as an individual person or even a service, even someone providing a service, how do you sort of go through that system? I think that's becoming ever more complicated. And there is potentially a danger in moving to regional systems that things get sucked up into more of a regional layer. It's not to say the regional layer is wrong. It's got a real role to play. But how you get the place and the person and the region and the national working in a sort of coordinated way when the statutory legislation isn't quite there yet is, I think, a really important tension to sort of tease out and tease through. I think the second piece is around staff. So obviously we've seen huge pressures on the NHS social care and public health staff that have come in through the pandemic. We went in without enough staff. Where are we going to find the healthcare workforce of the future? This is not just a UK problem. This is a global issue. And there are real concerns that if you actually, the current model basically involves us going internationally and recruiting people internationally, which has both practical problems at the moment as a result of COVID, but also hugely ethical issues around bringing people from healthcare systems who need their own staff to the
I have lost Richard. I don't know. Have you lost Richard? Okay, everybody's nodding. Let's just wait. Count till 10. Oh, there he is. Richard,
I come back now. Just drop off.
Back now. Okay. If you could wrap up as well, that'd be great. But
okay,
really
I'll just wrap up. Sorry, my internet this morning is just a little bit unstable. So I was actually talking about technology, ironically, as well. So yeah, the kind of the trade-offs of the technology, and then so there's these sort of big changes that COVID is driving that we need to understand, and we need to make sure that work for those who use and work in the services. And then I think for the voluntary sector, there's 3 opportunities, and they're around what I've called projections. So I think there's a projection of evidence, which is, as I said in my opening, exactly what National Voice has been very good at doing. And thinking through, I mean, Charlotte, it's amazing that you don't have a communications team, but are still able to get media coverage. That is a huge testament to the organisation. But if you look at, say, the Marcus Rashford campaign, you know, who can be your advocates and to take it to that next level? So there's a projection of evidence. There's a projection of capability. And one of the challenges I think the voluntary sector often faces is, because it is a range of different players operating in very different ways, how you can formalise that engagement and capability and what it is you're actually providing is, I think, really, really important. So I think there's a piece on evidence. I think there's a piece on projection of capability, and then there's always tension with the voluntary sector. And Ben's obviously been in government sort of many years ago looking at this, which is what's your role as a partner and a challenger. And there will be bits of government policy that people on this call will absolutely vehemently disagree with and have absolutely every right to. But there will also be opportunities to try and go in and have that partnership conversation. And it's that tension and that scale that you're constantly having to try and play with. And I think trying to work out where the alignment opportunities are with the system, whether it's the NHS or the department, and also where you actually do want to go out on your own and actually make a case to actually make the changes, which indeed National Voices has done over the last few months, is, I think, something that is going to only become more important, of working out where to play on that scale over the coming months ahead. So that was just some opening remarks from me. Sorry my internet went down at that sort of juncture, but hopefully I'm back now and able to contribute to the remainder of the Q&A.
Thank you so much, Richard. Really interesting. Lots of food for thought, I think, for everybody on the call, and also for me and for the National Voices team to reflect on. As always, these things are all in tension, aren't they? And it's the intelligent place to be is to hold that tension, really. But what that means in practice needs to obviously be worked through. Right, one of the veterans really of influencing in this space is Sally and the Centre for Mental Health. Sally, do you want to give us your reflections on, what's happening with mental health, but also what do you think is the role of our sector in making things better for people?
Thank you. So first and foremost, thank you very much for inviting me here today. It really is a pleasure to be with you all. And it's always important for me as another human being to acknowledge that, we are all facing deep challenges now. And so I'm in solidarity with you all in your respective places, facing what is a daunting winter ahead of us. So I think it's, you don't need to be a rocket scientist to understand that mental health across the world is at its most fragile than I've ever seen in my lifetime, and I suspect, has been for the last 100 years. And we know very early on in the pandemic, we knew the evidence was very clear that calls to helplines, etc., went through the roof. We saw up to 300% increase to some helplines. Now that has, moved up and down as we've gone along. And the Centre for Mental Health, we've been developing forecasts at various intervals as we go forward. And about a month ago, we launched our third forecast that we had been working with NHS colleagues on to help local areas understand exactly, what was going to happen in terms of need and demand. And as a result of that forecast, we identified up to 10 million people who will need extra mental health support as we go forward over the coming year. 8.5 million of those people will be those with existing mental health problems, but we're talking about an exacerbation directly in response to the pandemic. Now, I have worked in the third sector for all of my professional life, 30 years of having the privilege, and I absolutely know that the third sector stepped up in a way that we all in this Zoom room can understand and imagine. You know, we saw overnight transformation that we'd never anticipated. Online services, people being really creative with the partnerships that they were developing. So in my old stomping ground, CPSL Mind developed a great partnership with the digital mental health provider Hughes, so that they could rapidly transform and start providing services into people's homes. And they were able to do that within a matter of days. We saw the most extraordinary system leadership and engagement of the third sector, especially in Bradford, the famous Kim Shuttler, who has been doing extraordinary work, really closing in on, you know, working with public agencies, public service agencies and other third sector partners. And really, I think that that has set a tone for how we want to pursue mental health in the years to come. We as a group of national charities also developed the new social contract, which we have invited government to consider, which is about taking this moment of deep despair and distress, which, you know, is an enormous challenge, but really taking this as an opportunity to deal with some of the things that we know are causing the most problems for the people that we care about. Let's face it, we're all in this ocean together. This is a collective trauma, but we are not all in the same boats. So as a result of that, we know that there are people who are incredibly vulnerable. We know that there are small groups of people, pockets all around the country, that are suffering in a way that no policy at the moment is dealing with. And so my challenge really to Ben and other colleagues is really thinking about policy that attends to people's needs locally. So we tend to kind of go for a national approach, and I'm very much in for that kind of place-based model of thinking. One of the things that I also think is a challenge as we go forward is the reality that the third sector is under threat. And so I hate to be the voice of doom, but we have got to face the truth that we've got a bit of a government that's not that, well, it doesn't seem to be that fond of charities right now. And we've had quite a lot of kind of negative messages about our role and value. We know that grassroots charities that are working with our most vulnerable groups, especially around equality, Black and minority ethnic communities, women, you know, disability, those organisations that are working at a grassroots level are at threat of disappearing over the next year. We know that. So when we talk about the fabric of the third sector going forward, we have to have some realism here about actually what that will mean. I think that there is a risk that we will be excluded from local systems and planning, and I'm urging people to get your elbows out and force your way into those tables. I think Charlotte is brilliant at doing that. So I'm learning from you, Charlotte, and I've got my elbows out every day of the week. But that's what we need to do. We need to cultivate space for ourselves and the people that we care deeply about. Look, I'm really worried about the mental health of the nation in a way that is really difficult to convey without sounding, you know, that I'm, you know, frightening and hopeless. Of course, there is hope, but only if we absolutely truly attend to the deep and decades long inequalities around poverty, exclusion and discrimination. So this pandemic you know, is affecting people in ways that we will see for generations to come, but some of it can be mitigated. So when we're thinking about the economic impact, which is in our view going to have the worst impact on mental health, we therefore welcome the government's decision to extend the furlough scheme. We welcome the government's decision to extend the universal credit payments, but that's nowhere near enough. And so we will not stop banging on those drums. And we urge all of you to join in that campaign, the Never More Needed campaign. If you've seen it, that infrastructure bodies are creating, please do use that campaign. And also to really think about your organisation and how are you thinking about, you know, not only the mental health of the people in your communities, but also the mental health of your staff and the people that you're working alongside. So I'll leave it at that, but I just want to say to you that, you know, lots of work is going on behind closed doors in terms of mental health, and there is a profoundly strong coalition of mental health organisation that is knocking down the door of number 10 right this minute.
Wow, thank you, Sarah, for this impassioned plea for putting mental health front and centre, which I think is absolutely right, both as an outcome of inequality. Mental health is a really strong indicator, but also as a factor that feeds inequality. And so if we focus on mental health, we can't go much wrong, really. And also for kind of the reality check around where much of the sector is at. Many of us have stepped up in the moment rightly without asking for payment, but that obviously cannot continue. And, you know, who will hold the deficits in the end that we accrue through this unprecedented challenge and the unprecedented need to spend? It certainly cannot be small grassroots charities, because they will not have the resilience to hold these deficits. So some solution needs to be found to make that work. Right, I'm kind of just maybe using chair's privilege to pick out one question that I think all three of you have touched on, and just to ask for very quick feedback on that before we hand over to the floor. All three of you touched on the tensions that are national in place, and where, you know, at the moment we're all over the ICSs. For those of you on the call who don't know what that is, the integrated care system, a number of those have been set up and are being created by NHS England as a sort of regional infrastructure between where people live and where Skipton House sits, so to speak. There is obviously talk of reform legislation next year around this. Are we going to put ICSs on a statutory footing? Because at the moment they're just, you know, something that the NHS talks about in strategy papers, but they don't exist in law. We as National Voices were part of a working group that met last year, quietly trying to bring together all stakeholders in health, chaired by Ian Dodge from NHS England, to bring us behind a consensus of the kind of minimal amount of reform we wanted to see going forward in any reform legislation. So in a way, asking all of us to tone down our maximalist demands and to say, if you could only have one thing, what would it be? And we arrived at a package of suggestions that's now public and that we shared with our members, of the things that we think make sense to change. Now, for me, for changing yet again the acronym soup and formalizing this or unformalizing that was always the least important priority. But as these things go, it looks like it might be the thing that gets over the line. So I just wanted a quick response from the three of you. Where do you see this tension between the national and the place, and what hopes or fears do you have if this is going to enter parliamentary debate next year? What will happen around that tension? Maybe we do it in reverse order this time, and I ask Sarah to go first.
I mean, I think this is one of the things that we do need to try and resolve within the kind of policy space, which is, you know, when I worked on, you know, in organizations before I arrived in this job, I used to always think, you know, why can't policy just move more quickly, you know, because we have the evidence. So I agree with Richard's point, you know, we need to project the evidence, we need to do all of that, but actually we've got quite a lot of evidence. So for me, it's about helping local organizations really understand how to use the evidence, how to engage in systems in a way that is effective. You know, thinking about your point earlier on, Charlotte, about, you know, shouting doesn't help, although I do love a shout, I have to say, and, you know, that sometimes does help me. But the reality is that we do need to give local areas the capacity and the skills to use the evidence to understand how to influence, because actually, you know, there is an art to some of this, and so there's some of that, I think, in a local in a local sense that we need to achieve. But it's also incumbent on us as kind of national influencers and decision makers to also understand the nuance. And often we take the easy route by being very, generalist, and, we go big and we go for scale. And actually we're publishing our one of our equalities reports next week. And what we're saying is big doesn't always mean better. It's about giving local areas the resources, the levers to create and design their own system that works for them. Thanks,
Sarah. Richard, what do you think will happen when Parliament gets its teeth into healthcare reform legislation?
Well, the history is always that it becomes very political very quickly. I'd like to think on the creation of integrated care systems, there is some quite good alignment between the parties on what the objective is to deliver, frankly, more integrated care. But I would completely concur with Sarah on the need to not be overly prescriptive. And I think the way you'll get more local, place-based, person-centered care into systems is if you give systems the space in which they can actually do that work and actually have do that engagement. Now, what that may look like practically is it's guidance, good practice guides, sharing, etc., rather than actually hard legislation for how to do it. I think the days of setting top-down NHS organisational structures, I don't think that's worked particularly well. So my sort of overarching view would be to completely agree with Sarah. Let's not be overly prescriptive, and let's make sure there's enough space locally for areas to be innovative and flexible in how they go about their engagement.
Excellent. And Ben, what do you think? How will NHS England play this, and what do you think is going to happen around this whole tension around place and ICSs and national steer?
I mean, I guess the way I look at this is that we've got a national health service, and so there are some things which need to be national. But in terms of the reality of how do we deliver excellent care, there are at least two scales which are absolutely necessary. And the first is for acute care, which is a lot of what we ask the NHS to do, having a integrated care system level footprint where you have a specialist hospital and 2 or 3 district general hospitals is almost, is basically quite a good level to operate at in my experience. And that's why we've got 42 of these sub-regional systems at different stages of development. And I think there is a real commitment to seek to make that the kind of overall planning level for how the NHS operates. And so in terms of voice and shaping strategic plans, that is the space to engage with, I think. Beyond that, there's some things from the NHS will be done, many things done through regions, which are groupings of those, national programmes coming down, cancer alliances, slightly separate, etc. But that's the system level, which is really important and aims to have baked into it a spirit of collaboration within and beyond the NHS. But we also know that in terms of some of the things we're talking about people's well-being, around mental health, personalised care, it is the local level and the primary care network level where the opportunities for some of that mutuality that I was talking about and others have mentioned as well, getting that interaction right has to take place. And so I would say focus for voice efforts at the system level in terms of the NHS planning side, but really the task is to support primary care networks and their partners around community care. And the challenge there is that they are not very developed organisations and networks. They have very little central capacity. And so getting that partnership being, effective and easy, as we started to do around social prescribing in some places, is critical.
Thank you so much. we always say, half jokingly but half seriously, we quite like the fact that primary care networks have very little central capacity and are all about the delivery, because that's like us. We all have very little central capacity, and sometimes that's a good thing, because you've got less clever people writing clever papers. But yeah, I take your point. Obviously, these are new organisations, if you can even call them organisations, and it's hard to kind of engage with them systematically and effectively at that point. Right. I'm now going to ask, I think, Rebecca to start with, our head of policy, to tell me, because I haven't really been able to look at all the things that have popped up in the chat. Thank you for all of you contributing on the chat. Questions for the panel or comments or thoughts? Rebecca, what's coming up?
Okay, so this is not drawn so much from direct questions, but just sort of what I think people are talking about. And there are sort of three main themes that I picked out here. So one is sort of just following on from this question of sort of how to unlock things, how to get a seat at the right tables at national, regional, or local levels to have that influence. And I think it might be helpful if sort of there was some, if anyone has any further top tips beyond developing an evidence base and having the capability and then thinking very artfully about how to use that evidence. If the panelists have any more thoughts on that, I think that'd be really useful for the people on this call. I think there's some concern, obviously, picking up on what Sarah said about this, you know, the realism, the disjoint between the fact that, of course, the VCSE have stepped up and can do amazing things in this space to meet informal health needs, but at the same time, funding is collapsing, charities are going under, and sort of what do people do in response to that? And then finally, there was a question that was about social care. And I wonder, are the two the same in terms of a sort of policy influencing response? Are the sort of reform efforts that are needed to try to get social care the attention that it absolutely needs and deserves the same as they would be for health? I think that would be a really interesting thing to explore a bit as well.
Excellent. What a wonderful set of questions. None of them very easy, really. So yes, I was also thinking that we have touched on the fact that it's been really hard to engage with central government. It's been maybe somewhat easier to engage with some of the NHS structures locally and nationally, and also local authority structures. I think many of you, not so much National Voices, but many of you who have local footprints or are local organisations have done extremely well in getting into the right conversations there locally. But where we kind of have maybe failed to make an impact is to argue for us as a sector, you know, what do we need as a sector by way of funding and support, but also around the social care ticket, where, you know, how are we going to break through? So any of your any reflections you might have on this, the people on this call would, you know, really lap them up. I think I'll start maybe with Richard. Richard, you have hinted at, like, you know, the kind of difficulty of getting a hearing at the top table, particularly in this very politicized environment. Can you just reflect on what you've just heard from our members a bit more?
Yeah, I mean, I'm happy to come in on particularly on the social care side, which clearly I think, I mean, COVID's has really exposed the lack of action on this agenda for the last 20 to 30 years, and it's been absolutely tragic what's happened. And you've got to hope now that there is a genuine push, and I think there is an opportunity here to build a new case for social care reform. And this is not just older adults and care homes. It's much wider than that, in terms of how that system is properly and sustainably funded. What does good quality care look like? How does that care connect more closely back to the NHS, and that flow between the two systems work more effectively? And I think as we go through this very difficult winter period and out the other side, I think there is going to have to be a new opportunity to be making that case for social care reform. So we're doing a piece of work which is cross-party with a think tank called the IPPR on what that might look like. We feel that one of the challenges is that this often gets stuck very quickly on who pays for it and how it's all paid for. And actually, given that the government is spending billions and billions of pounds on furlough schemes and everything else, actually there could be a good opportunity now to actually say, well, look, this is an unreformed, underfunded sector. the cost of actually reforming it is less than £10 billion. This is a chance to put it on a more sustainable long-term footing and start to actually sort of develop a better framework for funding it. So I do think there's a new opportunity to make that case and to make those arguments that maybe there hasn't been previously on the back of how difficult it has been. I think the challenge, obviously, in the short term is the capacity at the centre of the system to absorb representation and complex policy and how it works. And we've seen already the Treasury say that they won't be doing a longer term spending review. So that's the framework that sets government spending. That will now be 1 year, and that will be announced later this month because of all the uncertainty. But I do think the next 12 to 18 months is a chance to ratchet up the pressure on government action on social care reform and to go in with some solutions and ideas about what that should look like. It's perennially kicked down, the can has been kicked down the road, but you've got to hope that after COVID that is no longer an option and that tough decisions need to be taken.
Really helpful. So you think riding the wave of profligacy to kind of remind people that money is relative and that funding can't be the be all and end all, and that we need to focus on reform consensus. Interesting to hear that you're working with the IPPR. That sounds like a really promising approach.
And I think, Charlotte, that one of the challenges with this is it gets very political very fast. And that's one of the reasons why it doesn't go anywhere. And both parties have been guilty of playing politics with this. And I think one of the reasons why we've teamed up with the IPPR is that actually we both think tanks agree that you need to have some sort of increase the level of provision and equity in the system as the first point of call. And that probably is some mechanism which they have in Scotland, which is free personal care. So the care element is provided similar to the NHS. That allows you to connect it more closely back into health services and gets you away from difficult means tests. There's still obviously the very toxic issue around home sales and moving into care homes for older adults. But you've got to start somewhere. And on the care element, I mean, there's big, wider structural challenges in social care, of course, around workforce and pay, and so the whole range of issues. But if we could get that care element properly funded, that would be a good starting point to then inject some change into the sector. So we've kicked off a piece of work with the IPPR. There should be more coming out on that in the coming weeks and months. But I think it's a good opportunity to start to show that there is a sensible centre ground on this. And that inaction is not an option. So I'm happy to keep you updated on how that goes.
Brilliant, thank you. Ben and Sarah, do you want to add anything to these thoughts that we've just heard of here? How do we unblock the blockages on social care or anything else? Ben, do you want to go first?
Oh, sorry, I was.
Sarah. Okay.
Oh no. Sorry, I was just going to say that I think that there has been so much thinking done in this space already. Health Foundation published a really great report at the end of last year about, exactly, what does social care need to look like. I think from a mental health perspective, actually there is still a lack of understanding of what social care looks like in a mental health sector. So I still talk to civil servants and others, and including people in the NHS and LGA and others, that don't really understand that social care is what funds much of the working age adults mental health services via the voluntary sector across the country. And so really trying to help understand that this is not just about older people, although I absolutely appreciate older people need to be taken care of. So again, it's about how do we get some nuance into this debate, really an in-depth understanding of actually, where does social care reach? Because actually it is far-reaching, and I'm not quite sure people truly understand that, not in government or in communities, actually.
Yeah, I think that is very true. People don't really know what it is.
No.
Right, Ben, any final thoughts?
It's hard for me to speak on behalf of kind of NHS E&I on sort of overall VCS funding. It's something that I've thought about personally quite a lot. And I actually had meant to start by acknowledging it's been an incredibly challenging time for many charities and social enterprises and wider voluntary and community sector. I do think that, coming back to what I was saying about mutuality and voice, I'm quite in the the kind of Julia Unwin to Danny Kruger spectrum of we've got to keep the independence of the sector and that connection to the, as it were, the members of the sector, I would say, as in the people who are involved, supporting, giving, benefiting from. And of course, we have a charity structure which doesn't always completely help that. Some other organisations, some other countries have more associational structures, which I think are really helpful on mutuality. And so I think my ask to government would be not just, and I don't have his NHS hat on, but not just how can we have emergency help, but actually how are we building structures which enable everybody in communities to contribute what they can, whether that's their time, whether it's their money, whether it's their insights to this sector, because it is through that those unique characteristics are able to be are come to the fore. And we haven't got time to work out how all of that does, but I would be pushing for that, for the things which will enable that as much as the immediate direct financial support, much as that is crucial as well. And in relation to the first question around evidence and contributions, I mean, I think the great thing about on the ground, the sort of primary care network level, for example, is that if you're doing a brilliant job, actually, those working in primary care will know that. They will see the difference it's making to people. And so quite a lot of that is be really making the best and most impactful difference working with people, etc. But of course, as I mentioned before, as we move up levels and we start to talk about the distribution of very significant amounts of public funding, it is important that we've got an evidence base to draw on. And I think that this is a discussion I think I've had with Charlotte as well. We want to, I think about how the networks and the engagement which you're all able to bring to that can then be, out of that can come more systematic understanding of need, rather than seeing systematic understanding of need as something which is completely done by different survey organisations, etc. So I think that's that thing that I was talking about at the beginning, about how do we bring together voice and more systematic insight is a critical area, but only once we get up to the sort of system and national level. I think that on the ground it's about, you know, demonstrating the impact it's making on people's lives.
Thank you so much, Ben. And thank you so much to all three of you for sharing your thoughts with us so generously and so passionately today. We are going to wrap this up now. We started with the formal AGM that our members attended, and then we opened it up to this wider discussion, and it's been a really interesting one. And thank you for all of you who contributed on the chat. If I might just sort of say what I'm hearing, but that's obviously because I run an infrastructure organization in the VCSE, that VCSE infrastructure is going to be so important in holding some of these tensions we've talked about here. We can only really harvest the richness that comes from the diversity of the work we do, the very informal and very personal and very local, and the more formalized and more standardized and more scalable. We can only really harness the richness of this and increase the impact of all of it, of the whole ecosystem, if we invest in infrastructure. And that's obviously a self-interested thing for me to say, but I'm saying it because I think it's true. We cannot wash up as 50,000 organizations and ask for an audience with Ben. But we can channel our insight and our energy and our work into coherent pieces of infrastructure arguments. And it's not just us, obviously, you know, Sarah runs interesting mental health infrastructure organizations and so on and so on. And collectively, we make this argument that we have been never more needed. And please do engage with that online and offline and in the real world. If you're on this call and you're not a member of National Voices, please do join. If you are a member, thank you so much for attending today and for contributing all the way through this last year and this last crazy period. Thank you again to the panelists. Thank you to Hilary, our chair, who very capably led the first part of this session, and to Rick and Jean, who looked after our finances beautifully and gave you the overview of that. Do stay engaged. But before we do that, have a good weekend, and I see you all soon. Take care.